Hi everyone, my name is Melissa and I'm a PharmD student. I'm going to be providing some feedback for the deprescribing activity that you guys completed in Lab 13. So first I'm going to start with a refresher of the activity and the case. We are a clinical pharmacist who provides services for different supportive living facilities, and we were asked by a physician in one of the facilities to meet with an 89-year-old patient to discuss opportunities for deprescribing. Mr. Smith has expressed that he's taking too many medications and he wants to reduce his pill burden. So there is a list of his medications there just to refresh which options we could be considering. So for question 1, list and prioritize potential options for deprescribing and what are the pros and cons of deprescribing each medication. The most common choices that students picked were indapamide, pantoprazole, and sertraline. There weren't necessarily right or wrong answers. We just wanted you to be specific in providing your rationales. So when listing the pros and cons, we need to consider efficacy, safety, and patient-specific factors when identifying appropriate options, and we wanted it to be clearly explained. So for example, if you chose to deprescribe pantoprazole, you have to consider what are the long-term risks associated with being on a PPI, such as increased fracture risk, decreased absorption of vitamin B12 and magnesium, and increased C. diff infections. And the PPI deprescribing algorithm is a really great resource for this information, as well as how to go about deprescribing. And it's also important to look at the temporal relationship between medications and symptoms. So if you looked at the timeline, you might have been able to identify that indapamide was actually contributing to the increased urinary frequency and the overactive bladder symptoms. So that would also be another reason why we would want to consider deprescribing indapamide. For question 2, are there any medications that you would not consider deprescribing, and explaining your reasons why? So the most common answers for this question were perindopril and amlodipine, because the patient has been stable on these medications for quite a while, as well as vitamin D, and then some groups also said sertraline as well. So just some things to consider is that the Beers list and the MedStopper list sertraline as a priority for deprescribing, but we need to look at patient-specific factors when deciding if this is appropriate. So for this patient, he has seen improvement since being on sertraline in terms of social engagement and appetite, and he has been on it for a couple of years and seems to be tolerating it well. He hasn't had any falls prior to his recent low blood pressure. For vitamin D, it does have benefits in elderly patients. Therefore, if we deprescribe it, we would want to engage in shared decision making with the patient, weighing the risks of deprescribing. So that could be reduced bone density, and it is difficult to get enough vitamin D in the winter months, especially if he's going to be inside a lot, and then weighing that against reduced pill burden. For question 3, which medication would you recommend to deprescribe first and why? And explain how you would go about discontinuing it. So most groups did choose indapamide as their first priority, and for this patient this would be the most appropriate option because there are safety concerns since he has had a recent fall and he is experiencing dizziness and lightheadedness, which puts him at a risk for future falls and even potentially fractures, and as well as its contribution to the overactive bladder symptoms. Next, we could consider pantoprazole as an appropriate option, and as mentioned previously, there are risks associated with long-term use of being on a PPI. And when considering if we want to taper or discontinue the medication, we have to consider patient-specific factors. So MedStopper did say that indapamide should be tapered, but if we consider the patient's safety, we might decide that it is more appropriate to discontinue the medication more abruptly. So we have to consider the immediate risks of the medication versus what will happen if we stop the medication abruptly. And if we are tapering a medication, we have to look at the formulations and strengths that are available for that medication. So we have to ask ourselves, is it actually feasible and practical to taper to that dose? And if we are recommending a taper to a physician, instead of saying reduce by 50%, they would expect you to specify which dose you're tapering to. For indapamide specifically, there are 2.5 and 1.25 milligram tablets. Therefore, a tapering plan could be to reduce to 1.25 milligrams for 1 week and then discontinue. And for the last question, describe your recommendation, monitoring, and follow-up plan, and be sure to include specific targets if relevant. So when choosing a blood pressure target, especially in older patients, the target should be individualized. So some things we have to take into consideration would be how healthy the patient is, in which case we might make a more intensive target if the patient is very healthy, what their life expectancy is, their goals of care, which is usually determined in a discussion with the physician, their healthcare team, and potentially even family, and the patient's goals, their risk of cardiovascular events, and their risk of adverse effects such as falls, dizziness, and lightheadedness. In general, monitoring and follow-up is where most groups lost marks for not being specific enough. So for monitoring, instead of using overarching terms for monitoring such as monitor for hypotension or hypertension, we have to be specific about what signs and symptoms to look for. So think about how you would explain to a patient how to identify if they are experiencing hypo or hypertension, other than just the numbers on their blood pressure monitor. Some groups mentioned that if the overactive bladder symptoms improved after discontinuing indapamide, they would consider discontinuing mirabegron. However, they didn't actually include monitoring for these symptoms, so that would be important if you wanted to potentially deprescribe that medication in the future. And for follow-up, if you have something that's being monitored, it should be followed up with. So if you say that the patient is to monitor for lightheadedness and dizziness, you should include follow-up for this in your plan. And just one more point is that some groups didn't include the patient in their follow-up plan, only the nursing staff. So this patient is their own decision maker and he is a good source of information. So it would be important to follow up with him to see how he is feeling since the medication changes, especially if you did say in your monitoring plan that there were specific symptoms that you wanted him to look out for. And that's everything that I wanted to go over. So I've included my email on this slide if you have any questions about the feedback or the assignment. So please don't hesitate to reach out. Thank you.